Good morning. Today our subject will be about menopause. Definition of menopause, it's a point in time of 12 months after women's last period. The years leading to that point, when women may have changes in their monthly cycle, hot flashes, other symptoms are called the menopausal transition or perimenopause. Menopausal transition most often begins between the age of 45 until 55. It usually lasts about 7 years, but it can be as long as 14 years. The duration can depend on lifestyle factors such as smoking, age, race, ethnicity. During perimenopause, the body production of estrogen and progesterone, the two hormones that are produced by the ovary, varies greatly and it started to decline. Menopausal transition affects each woman uniquely and in various ways. The body begins to use energy differently, fat cell changes, women may gain weight more easily. You may experience changes in your bone or general health, your body shape and composition, or your physical function. To understand menopause, changes in the period happens to start with. This might be the first sign that you notice. The period could be longer, could be shorter, could be regular, could be irregular. You might bleed more or less than usual. These are all normal changes, but to make sure that there isn't a problem and see the doctor if it happens to be more frequently, heavy bleeding, heavy spotting, period more than 1 week. So the period is a marker of a probable impending menopause or maybe a more sinister problem. Your period resumes after no bleeding for more than 1 year. The hot flashes, women may have hot flashes or may not, which can last for many years after menopause. They may be related to changing in estrogen level. A hot flash is a sudden feeling of heat in the upper part of the body. The face, neck may become flushed. Red blotches may appear on your chest, back, and arms. Heavy sweating, cold shivering can follow. Hot flashes can be very mild or very strong, that it can be disruptive to the patient's life. Most hot flashes last between 30 seconds to 10 minutes. They can happen several times in an hour, or a few times a day, or just once or twice a week. We can find information about how to manage hot flashes. Also, bladder control. Loss of bladder control can occur, and it does lead to incontinence, which may have sudden urge. The incontinence is sudden urge to pass urine or leaking urine during exercise, sneezing, and laughing. The first step in treating incontinence is to see a doctor. Bladder infection can also in the midlife can cause this problem. Around midlife, some women start having problem getting a good night's sleep. Maybe they can't fall asleep, or they wake up too early, or have frequently interrupted sleep. Night sweat might wake you up, and if you wake up, this will be difficult to go back to sleep. We have to learn how to improve our sleep during the menopausal transition. So what can we do? To start with, vaginal health and sexuality. After menopause, the vagina becomes drier, and this can make sexual intercourse uncomfortable. To read about options for addressing vaginal pain during sex and menopause, you can refer to many articles. Treatment for symptoms. You may also find that your feelings about sex are changing. You could be less interested, or you could feel freer and sexier because after 1 full year without a period, you can no longer become pregnant. However, you can still be at risk for STD, such as gonorrhea and HIV. chlamydia, all sorts of sexually transmitted disease. So for this particular problem, you have to be very careful and use condom all the time. Basically, menopause, as we said, has different presentation. The first one will be the vasomotor symptoms. These are the cardinal symptoms of menopause, affecting more than 3/4 of women in midlife. The symptom could last from 5 to 7 years, although some women continue to experience symptoms longer than that, about 10 to 15 years. Hormone therapy was previously the mainstay of treatment, but other options are now needed because hormone therapy may not be the best treatment or the treatment of choice, as there are many medical contraindications, as hormonally dependent cancer. As a result, surveys suggest 50 to 80% of midlife women uses non-hormonal therapy for vasomotor symptoms. Vasomotor symptoms are the complexity of urogenital syndrome. Close to half of the postmenopausal women have symptoms of genitourinary discomfort, also known as genitourinary syndrome of menopause. The genitourinary syndrome of menopause include, but not limited to, dryness in the vagina, decreased lubrication with sex, painful sex, irritation, burning, itching in the vulva or vagina. Genitourinary syndrome of menopause is associated with physical signs that are attributed often to low estrogen level and is usually understood to encompass urinary symptoms as well, like urgency, dysuria, recurrent urinary tract infection. Grouping of all these symptoms together, reported signs and symptoms together as syndrome, created more inclusive and acceptable terminology for both patient and provider to discuss postmenopausal genitourinary discomfort. However, this may obscure granular difference in experience between individuals, and which symptoms or experience of symptoms might be responsive to certain treatment, and which symptoms are more likely to motivate people to seek help. Hypoactive sexual desire in postmenopausal women. Testosterone modulates sexual behavior. Testosterone and its precursor are synthesized by the ovaries and adrenal gland, with about 50% of circulating testosterone produced by peripheral conversion of androgen and precursor. Androgen level decline with age and drop abruptly after bilateral oophorectomy. Although serum testosterone levels do not correlate with the presence or absence of hypoactive sexual desire disorder or its severity, there is a correlation between testosterone concentration during therapy and improvement in sexual desire. The hypoactive sexual desire disorder is estimated to prevalence estimated to be 12% of women between the age of 45 to 64, and is defined as persistent or recurrent deficiency or absence of sexual fantasies and desire for sexual activity with marked distress or interpersonal difficulty. A thorough clinical assessment should involve identification, modification, management of biological, psychological, sociocultural, interpersonal factors contributing to the problem. Evaluation include asking about all aspects of sexual functioning, including arousal, orgasm, pain, as well as targeted physiological, gynecological examination, laboratory testing when indicated. The diagnosis is mainly symptoms of menopause. Age, symptom of menopause, tell most women they have started the menopausal transition. If you have any concern of irregular period, hot flashes, talk with your doctor. In some cases, further evaluation is recommended. Tests typically aren't needed to diagnose menopause, but under certain circumstances, your doctor might require to do some blood tests. Follicle-stimulating hormone and estrogen level. Because follicle-stimulating hormone and follicle-stimulating hormone increases and the estradiol level decreases as menopause occurs. Thyroid-stimulating hormone is important because of hypoactive thyroidism can cause symptoms similar to menopause. The treatment, this is a broad subject. In the past, past 20 years, hormone therapy was regarded as the mainstay of the therapy. But as the Women Health Initiative study came out in 2002, it was found to be associated with many risks. So the trend of treatment is reversed to, first of all, lifestyle modification. The cool hot flashes, dress in layers. To treat hot flashes, you can dress in layers, have cold glass of water, or come sometime to some place which is cooler. Try to pinpoint the trigger, what triggers your hot flashes. For many women, triggers may include hot beverages, caffeine, spicy food, alcohol, stress, hot weather, and even warm room. To decrease vaginal discomfort, try over-the-counter KY gel and lubricant that can help. You might consider choosing a product that does not contain glycerin, which can cause burning and irritation. If you are sensitive to that chemical, staying sexually active also helps with vaginal discomfort by increasing blood flow to the vagina. Sleep. Enough sleep is important. Avoid caffeine, which may make it harder to get to sleep. Avoid the drinking. Too much of alcohol can interrupt your sleep. Exercise during the day, although not right before bedtime. If hot flashes disturb your sleep, you may also need to find a way to manage them before you go to sleep and get adequate rest. Practice relaxation technique. The relaxation technique as deep breathing, paced breathing, massage, and progressive muscle relaxation may help with menopausal symptoms. You can find a number of books and online offering that shows different kind of relaxation technique that will help with the problem. Strengthen the pelvic floor. The pelvic floor, when you strengthen it, there are various types of exercises. This is called, one of them is Kegel exercises. Now, a physical therapist that is trained for urogynecology exercises is very important here, as she will tell the patient how to do the exercises. There are many ways. Kegel is one of them. The use of Plevnik devices, which is polystyrene devices, small, that the patient inserted in the vagina, and the patient is asked to make contraction around it, and that repeatedly increases the strength of the pelvic floor. Or there is something called electric faradism, which is kind of patches like the X-ray, like the ECG, and a small electric current that help to stimulate. Also, if we continue non-hormonal treatment, we practice relaxation technique, deep breathing, paced breathing, guided imagery, massage, progressive muscle relaxation may help with the menopausal. It's very important to have a balanced diet, including variety of vegetables, fruit, whole grains. Limit saturated fat, oil, and sugar. Ask your provider if you need calcium, vitamin D supplement to help meet the daily requirement. Do not smoke. Smoking increases the risk of heart disease, stroke, osteoporosis, cancer, a wide range of health problems. It may also increase the risk of hot flashes and bring on earlier menopause. Exercise regularly can get regular physical activity. Most they help to protect against heart disease, diabetes, osteoporosis, and other problems that comes with aging. Alternative medicine. Many approaches have been promoted as aids in management of the symptoms of menopause, but few of them have scientific evidence to back up this claim. Some complementary and alternative treatment that have been or being studied is plant estrogen, bioidentical hormones, black cohosh, acupuncture, hypnosis, yoga. You may have heard of or tried other dietary supplement like red clover, kava, dongoquay, DHEA, evening primrose oil, wild yam, which is a natural form of progesterone cream, scientific evidence of effectiveness is lacking, and some of these products may be harmful. We go to the subject that is very important, which is hormone therapy. Is it right? Now, hormone therapy is again wide project. At some stage, as I said before, it was a routine to discuss hormone therapy with every patient that is going through menopause and prescribe it. The WHI study, the Women Health Initiative study that was performed in 2002, came out with different perspective and divided the complication of hormone therapy into two, short-term and long-term. The short-term is increased risk of thrombosis, and the long-term is increased risk of cancer of the breast. One of the short-term complications could be increased heart disease in the first 2 years of taking the hormone therapy. Now, this is a very important issue. Before, they used to say women are immune to heart diseases after menopause because of lack of estrogen. Now, this proves to be different with the use of hormone replacement therapy. There are mainly different types of hormones. Systemic, that is estrogen, progestin that comes together in a patch or a pill or injection. And there are local vaginal cream, which can be still used temporarily on a sporadic occasion to moisturize the bladder, to moisturize the vagina, and reduce bladder symptoms of incontinence and irritability, and to make sexual intercourse much easier. Now, we can go on and on and on discussing things about hormone therapy. Every patient has to read enough about WHI study, and this is what is called informed consent, and get to her primary care to request it or refute it. As I said, different complications can happen with it. Certainly, hormone therapy should not be prescribed to a patient with family first-degree relative breast cancer, patient with family history of thromboembolic disorders, so on and so forth. Well, I'll come to the end of this lecture. I hope it can be useful and it can highlight some of the problems that happen with the menopause. Thanks for listening.